Thank you very much, Mr. Chairman, ladies and gentlemen. This is a study which was done about 2 years ago, and I would like, since I have a little more time than originally anticipated, I would like to give you some background information. So this is a small study, 32 men with metabolic syndrome and newly diagnosed type 2 diabetes, and they had hypogonadal testosterone levels below 12 nanomoles per liter. That was our definition. And all these patients received a supervised diet and exercise program, and 16, half of them were randomized to receive, in addition, testosterone gel, fixed dose, no up titration, no down titration. This was a fixed low dose regimen. And then we measured quite a number of parameters related to type 2 diabetes, and I will also give you some of the original results. Originally the study was designed for 1 year. And then we were curious to see whether, if we followed these patients for another year, whether these results that were obtained during the first 12 months were maintained. So, just to give you the baseline design of the study, men were between 35 and 70 years of age, newly diagnosed type 2 diabetes, HbA1c between 6.5 and 9%. The waist circumference in all these patients, all of them had metabolic syndrome, was above 100 centimeters. In fact, they were in the area of 116, 117 centimeters waist circumference, so quite obese. They did not receive any oral anti-diabetic medication, nor did they receive insulin. There were no major diabetic complications, and they had no contraindications to testosterone treatment. Now, the diet and exercise regime was actually quite moderate, and these men were asked to walk 3 times per week, 30 minutes. This population, or this particular group, had probably not walked in the last 20 years. So this was a very moderate initial approach to get them to do a little exercise. Then another 3 times per week they were asked to do muscle training, and again this was not going to the gym and lift 100 kilograms, but it was very, very moderate training with elastic strings and things like that. There was no strict diet, but they received a very, very good education, a good training on what to eat, what to avoid, and it was more towards the Mediterranean diet, and they created the 25% rule, meaning that they should always leave 25% of their portions on the plate and not eat everything. Then there were recommendations about beverages and so on. I think the secret of this whole study is there was very, very intense individual coaching. They were contacted twice per week by phone or by SMS for a full year. There was a dedicated postgraduate fellow who took a lot of pride and time and effort to really educate these patients very well and keep them motivated. So I think this is the secret to this study. And then, as I said, half of the patients were randomized to receive testosterone at a fixed dose, and all of them underwent these lifestyle changes. So now you see a number of slides showing the results of the first 12 months. And you see on the left-hand side the group that received only diet and exercise intervention, and on the right-hand side, diet and exercise plus testosterone. You see the changes in waist circumference. The left-hand side indicates that these patients adhered very well to the recommendations, so they lost 6.7 centimeters waist circumference, which is a nice success. But those who went on testosterone lost more than twice as much, 14.6 centimeters, and this was significant between groups. When we looked at insulin, we see a similar picture. The diet and exercise alone group did very well, but those who went on testosterone did better, and it was again significant between groups. HbA1c minus 0.5% by diet and exercise alone, minus 1.2% by testosterone in combination with diet and exercise. And we looked at patients reaching HbA1c targets at 52 weeks. On the left-hand side, HbA1c of below 7%. All of the diet and exercise plus testosterone group reached this target, and about 42-43% of the diet and exercise alone group. On the right-hand side, the stricter criterion of a target of 6.5%, And again, there were still 88% in the diet and exercise plus testosterone, but none of the men who had only diet and exercise intervention received or achieved this target. We looked at prevalence of metabolic syndrome, two different definitions, the ATP3 criteria and the IDF criteria. And the diet and exercise group, all of them had metabolic syndrome to begin with. So the prevalence was lowered in the diet and exercise alone group, but lowered much more and significantly in the diet and exercise plus testosterone group, where according to ATP3 criteria, more than 80% did no longer fulfill the criteria of metabolic syndrome, and about 2/3 did no longer fulfill the metabolic syndrome criteria according to IDF. Now, and this is the new things, because what I told you before as an introduction is already published, but now we wanted to see whether these benefits of the testosterone group were maintained after discontinuation of testosterone treatment. And that's what we did after 12 months. We took all patients off testosterone with the exception of one who refused to get off testosterone. But 15 stopped testosterone treatment, and then we looked at the results after another year. So before we stopped testosterone treatment, we reinforced the diet and exercise program. We re-educated the patients and tried to motivate them to hang in. I think it was not so difficult because most of these patients had really experienced the benefits of losing weight, of reducing the waist circumference, of having a healthier lifestyle. And so they more or less maintained these new lifestyle habits. So you see, the vertical line is the 52-week line where patient or half of the patients still receive testosterone. And then on the right-hand side of the slide, on the right half, you see the levels after discontinuation of testosterone. And you see the testosterone group in blue and the diet and exercise alone group in blue, in red. And surprisingly, the benefits of the testosterone group, of the group that had originally received testosterone for 1 year, was maintained. We see the same with the BMI. So the delta between the two groups was maintained after the second year of observation. We see the increase of HDL cholesterol. I haven't shown you the original data before, but there was a very nice increase, particularly in that group that received testosterone. And this increase was maintained over time, so the results were quite stable. Then we see the drop in triglycerides. Again, the difference between the two groups was maintained. HbA1c, there's a slight upward trend, but it was not statistically significant, and we see that the difference between the two groups was maintained. In glucose, same picture, and again we see an upward trend here. Same with insulin, but the difference was still in favor of the testosterone group. And this is, we also measured some inflammatory markers such as the highly sensitive C-reactive protein. And there is a drop in the testosterone group, actually in both groups, but it was in favor of the testosterone group. So in conclusion, these beneficial effects of testosterone treatment in men with diabetes and metabolic syndrome continued for at least 12 months after discontinuation of testosterone. And we think that testosterone might be very helpful in kickstarting, in triggering the onset of better lifestyle habits. And it may be used for a limited period of time, but I think that patients who are testosterone deficient to begin with, who are obese, they may really benefit from an initial treatment period with testosterone because it not only improves the body composition, but it certainly does improve the motivation of these patients. Thank you very much for your attention.
Yeah, thank you for elegant experiment. Question, please. What is the dose of testosterone?
The dose was 50 milligrams of gel, which is the equivalent of 5 milligrams of testosterone per day, and it was a fixed dose. We never changed this dose. I think that had we used somewhat higher doses, we may have even seen a better effect, because some of the effects of testosterone, for instance, on body composition, but also on insulin resistance, seem to be dose dependent.
Okay, question, please. Yeah. Use microphone.
I am Dr. Yan, an endocrine fellow from St. Luke's, from the Philippines. May I ask, did you measure the level of the testosterone?
Yes, we did.
The baseline and follow-up testosterone level?
Yes, testosterone levels were under treatment, went from below 12. The average level was in the range of 10 nanomoles per liter, went up to 15, 16 nanomoles per liter. The group that was on diet and exercise alone had a slight but significant increase of testosterone levels as they lost weight, but this didn't bring the testosterone levels into the normal range.
Yes.
Thank you.
Pradana. Okay.
From Indonesia. Nice study, I see. But you mentioned that you don't give anything for diabetes treatment. So, or maybe later after 1 year you combine with anti-diabetic.
No, we did not. At this particular study, we did not add any oral or other anti-diabetic medication because patients did actually quite well, and it was, as I said, newly diagnosed type 2 diabetes without major complications. So we thought that our philosophy was that we should really go for the changes in lifestyle and have this as the main parameter or main principle of treatment.
Yeah, you mentioned that you can reach, most of the patient become non-metabolic syndrome.
Yes.
Right. But you didn't mention about the HbA1c level that they can reach. All the patient can reach the target of HbA1c level.
Yeah, not all of them did, but the majority on testosterone did. And so we are not quite sure what to do in the future. If the HbA1c tends to go up again, we might put them back on testosterone, or we might also add other types of medication.
Thank you.
What's your explanation or hypothesis on persistent effect of treatment with testosterone in this patient?
The fact that the effects were maintained are certainly due to better and healthier lifestyle that we managed to induce in these patients. Testosterone as such has certainly some direct effects, certainly on body composition. That's probably the key in these newly diagnosed type 2 diabetics. And these effects are very, very consistent. One needs to consider that adipose tissue suppresses testosterone production because it produces a lot of estrogens, it produces cortisol, it produces some substances such as leptin, which have a direct suppressive effect on endogenous testosterone. So we think that as we normalize these patients' testosterone levels, they are also in a better endocrine situation to lose weight. So this is one thing. The other thing that has been shown in very elegant experimental studies is that testosterone has a direct effect on insulin sensitivity. And this has been shown within 48 hours in experimental settings. It's at Harvard University. Peter Liu is the first author of this paper. And this is certainly not mediated by changes in body composition, but there's a direct effect which is as of yet unexplained, but it is there.
Okay, thank you. Any more questions? Yes, please. Yes, Kyo, okay. Let Kyo ask a question here, okay.
Thank you. I thought there's some experimental evidence suggesting that, say, NOD minus, that is the testosterone that induces the diabetes as well. If you breed NOD minus, the females don't get diabetes so much, but if you give them testosterone, they tend to get diabetes. I'm just wondering, you think it's via the increased physical activity from testosterone that produce these changes? Why are these people low in testosterone in the first place?
Well, because they are obese. And I think that's the main reason why they are low in testosterone, because adipose tissue suppresses endogenous testosterone production. I think that's the key to this whole issue. And these men were quite obese. They had waist circumference of 116, 117 centimeters. And I think this is reason enough, and many studies have shown this, that the substances produced by the adipocytes suppress endogenous testosterone production via negative feedback on the hypothalamic pituitary unit, But for instance, in case of leptin, it has also been shown to have a direct effect on testicular testosterone production. So I think these patients are primarily hypogonadal because they are so obese. And then I think that the effects are multifactorial. It's not only the reduction of weight and of obesity, but at the same time, testosterone will increase lean mass and muscle mass, which none of the weight loss drugs does. But testosterone increases the lean mass, which is equally important for diabetics because that's the site of the glucose metabolism. Then it increases the motivation. It's much easier for these men, if an obese man is hypogonadal, he is lazy, very, very difficult to motivate to do anything in terms of physical activity. But as they get their testosterone levels back to normal, they will be much easier to motivate, and they will be motivated endogenously to increase their physical activity. So I think that's another thing that certainly needs to be taken into consideration. And then, as I mentioned, testosterone has a direct effect on insulin sensitivity.
Please.
Good afternoon. I'm Dr. Rosario from the Philippines. Anyway, my question is just a follow-up to my colleague's question. What happened to the testosterone levels after you removed the testosterone, the 12 months after? You mentioned that it went up, but did it go down again?
Well, to be honest, I don't quite remember. I think they went slightly down again, but they were certainly above baseline. And again, I think that once you have a man reduce considerable weight, then his own testosterone production will come back because the adipose tissue suppresses testosterone. But to be honest, I don't remember the levels that were achieved, but they were certainly significantly above baseline.